Welcome to the Critical Care Obstetrics podcast. I'm Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics, and I'm here with my partners, Suzanne McMurtry Baird, our Nursing Director, and Julie Arafeh, our Simulation Director at Clinical Concepts in Obstetrics. Today, we decided to take a different approach. Recently, I released an episode titled, "Would You Have Sent This Patient Home?" where I interviewed a postpartum sepsis survivor about her experience becoming critically ill and kind of what that looked like from her perspective. So I wanted to bring Julie and Suzanne in so we could do a debrief of sorts and talk about it, because I offered my insights during my interview with Andrea, but Julie and Suzanne have different perspectives, and this was such a compelling story that we all thought it would be a great idea to just kind of regroup, get together, and talk about our thoughts about what this patient went through, and just some more information, more insights on how this can impact you in your own facilities and in your own practices. So I thought I'd start by just asking each of you guys, Julie and Suzanne, what stuck with you after you heard the podcast? And listeners, if you haven't listened to the podcast, I strongly recommend you go listen before you hear our debrief. I mean, there will be some spoilers, but but it helps give context to what we're going to talk about. So, Julie, what was your impression after you listened to that story?
Well, first, I had a very emotional response to that story. And I actually told Stephanie I thought she did an excellent job, because I actually had tears running down my face through part of that story. And for me, I kept thinking to myself, I wonder how many people are thinking, you know what, this couldn't happen in my hospital. This is a very sad story, but it couldn't happen here. Obviously, I was struck by, have they prepared for emergencies? What have they done to make sure that something like this doesn't happen in your hospital? Maybe you don't understand how to go through the process to make sure something like this doesn't happen. And for some nurses and physicians, their hospital's just not going to support that kind of work, because it doesn't fall neatly under education. It doesn't follow neatly into data collection for quality improvement. It's a very action-oriented quality improvement project. Those were my main impressions.
What about you, Suzanne?
Yeah, it struck me, and we know the statement that I'm going to make as a healthcare provider, as a nurse. I know that the patient is always affected. Their family is affected by these cases, and that is what is behind the data that we sometimes don't discuss. And I'm so glad that we have these organizations out there now that are doing some of that work, which is where we came in contact with this particular patient, was with an organization that is telling these patients' stories now. And I thought it was so impactful for her to say, it's a patient, it's a family, it's a community that's impacted. And I was just so struck with her saying she had regret. And I thought, why would you have regret? I mean, the system failed you. It didn't have anything to do with you, but she was, saying, what could I have done? What else could I, and I'm sure her mom probably feels the same way, or her family member.
Yeah, that struck me too, especially where she was really regretting that she went back to the same hospital, which is exactly what any of us would have done, and what, as a physician or a nurse, we would have instructed them. That would make the most sense, but that was a big point of regret for her. That's a big weight she carries.
I know, and I just really felt for her on that. The other things that I thought were some of the things that we've talked about a lot. Normal patients, normal low-risk patients, can all of a sudden be abnormal and can turn high risk and critically ill. And that was a big component of this. I thought there was a complete lack of knowledge by OB, and I'm saddened by that, but complete lack of knowledge. There was no standardized recognition or management protocols for a patient like this. And so it made the patient, it went back on the patient, making her assume that it was her fault or that it was something, wrong with her anxiety and things of that nature. And so then I also thought this really came down to hospital culture. Um, and we'll talk more about that, but I think the hospital culture has an opportunity to improve.
Yeah, I agree with all of those points. And a couple of other things that stuck out for me, in addition to that, blaming the patient. I really felt like there was a lot of responsibility being put on the patient and her family that was disproportionate. I mean, yes, there's patients have responsibilities for their care. You have to show up. You have to communicate. You have to, communicate your concerns, questions, whatever it is, because we're not mind readers. She was definitely communicating, at least from her perspective, which is what matters, what was going on. But another thing that struck me was after the whole event, like, we focus a lot on what happens during the event and leading up to the event. And, we're going to talk a lot about that today. But when a bad thing happens, how do we handle the patient and the family after the event? Like, what do we say to them? How do we say it? How do we explain what happens? Like, I can share that, like, for example, when I'm in the office, I see a lot of patients for a preconception consult, or maybe they're coming pregnant and they had a bad experience or a bad outcome or whatever in their prior birth. And I always offer to get the records and review them and explain to them what happened, because most of the time they don't really understand what happened. They
Yep.
just that closure never took place, that explained this is what happened at a time when they're ready to hear it and process it, not when they're critically ill.
And oftentimes because of that, they seek legal advice because they want to see their records. They want someone to explain what happened to me. I want to know. So either they can go the direction of like seeing somebody like you to explain that, or the other direction that sometimes happens in these cases is they go to a lawyer.
I think this is where education and simulation can work very well together. I was debriefing a group of practitioners at a hospital, and it was after a bad outcome. And we invited both a patient liaison that was supportive of patients, and as well as risk management that actually gave the staff the words that you can say to patients to get this type of a review going, but to not give them, but to make sure that you're not implicating or giving them an idea of something that you really don't know what happened until you do a case review. So instead of going in and saying, wow, I can't believe that anesthesiologist did that, is saying, we're going to take a very close look at this case. And when we're done, we want to sit down and go through with you what happened. So those types of words and giving staff those types of sentences to say, I think are very important.
Yeah, and I think there's a lot of fear from the individual providers and the facility that when you have an outcome, in this case, the ultimate outcome was good in that we both mom and baby survived intact, but it's not always that case. And even when the outcome is apparently good, there's still trauma involved, and there's fear of legal repercussion. And so sometimes providers, nurses, physicians are um, instructed not to communicate, or only to communicate in specific ways, or they're just fearful and avoidant because they don't know what to say or how to say it. And that leaves the patient and the family feeling, potentially further abandoned. And like, as she said, that she felt she never had closure. Like, if you'll remember in the story she told, there was one physician who basically told her to, you're being crazy, stop this. She never saw that doctor again. Yet that doctor's actions had a significant impact, not only on her outcome, but her experience and her memory of this whole process. So I think systems, we need to do better at the aftermath, and not just the front end things. I mean, we got a lot of work to do both directions. We saw her in her story, and I'm so grateful that she was so willing and able to communicate so effectively her story, because we saw so many examples in her individual story about things that, if you've been listening to us for a while, we've talked about so many of these issues before. So we're going to kind of highlight some of the key issues. First, normalizing the abnormal. Now, think a minute yourself. You listen to this story. Just think of one thing that was done or not done that normalized the abnormal. I'll give an example of one thing that stuck out for me, and I'll let Julie and Suzanne weigh in. But first, okay, she's got chills. She's describing, she is essentially rigors, that she is like rocking in the bed with chills. And they tell her to calm down, take a hot shower, and they thought there must be a thermometer problem. We're going to call maintenance to fix the thermometers. I mean, that's about as dramatic of a normalizing the abnormal as you can get. I mean, you are a postpartum nurse. How many times are your postpartum moms in rigors, shaking, teeth chattering chills, and you think it's a thermometer problem, a thermostat problem? Suzanne, what was your normalizing the abnormal observation?
Well, I had to go with the anxiety part, and you highlighted that really well in the interview. She's a new mom, and so it made her really question herself. She'd had previous stint of anxiety, and so they just went with it, and like she really felt like she was labeled then from then out. And honestly, it sounded like she was, because it really affected downstream that ability to critically think about other avenues for the pathophysiology, in other words. So and then they sent her home on anxiety meds. So that one was really struck me.
What were your thoughts, Julie?
I was struck by the fact, I kept thinking in my head, where's the early warning criteria? Where's the early warning criteria? There is not a more clear view of what maternal early warning criteria does than when you're thinking about normalizing the abnormal. That's exactly why we have maternal early warning criteria, because some of these changes, they start and you don't get from very ill, and you don't move to very ill from fine in one fell swoop most of the time. It's all of these little steps along the way that lead you into this false sense of security that everything's all right. And that's what early warning criteria is supposed to do. It's supposed to give you fresh eyes and look and say, hey, wait a minute, this isn't right. We need to do something about this. So I think that's what struck me the most about normalizing the abnormal here, is they really didn't have the tools they needed to recognize this, obviously.
Yeah, and to your point, she relayed that she'd never felt her heart race like this. She said her heart was just racing, 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 and she was communicating this. She didn't know what her pulse was, but she was very symptomatic with her heart racing. And, we've all taken care of a lot of uncomplicated postpartum women, normal vaginal births. By day 3, they're begging to go home. I mean, they might, nobody's happy to be in the hospital on postpartum day 3 after a normal vaginal birth. They're like, look, I may be nervous to go home with my new baby, but I don't need help to go to the bathroom by that time.
Do they even stay in the hospital for 3 days anymore? I don't think they do. I think they're sending them home as soon as they can pee or something. It's like, get out.
Exactly, because they're, for better or for worse, you're pretty independent by that time. And the fact that she wasn't, like that, these are just major red flags. So that leads us to other things that we've discussed at length in previous podcasts, are systems issues. Okay, so like Julie's point, not recognizing abnormal vital signs. This can be hardwired. You don't even have to know what they mean. You just have to know not fitting criteria, must do this next. The maternal early warning systems, I mean, yes, it's nice if you have some knowledge of it, but you don't actually have to have knowledge of it. You just need to know abnormal, next step is this. And that's what these guidelines and protocols can do if you practice them. We saw significant delays, delay. And the delays were both a combination of lack of recognition of what is actually happening and a lack of response once things started happening. So, Julie, you want to share some thoughts on that as our systems expert?
Well, it was pretty obvious to me that there was a disconnect between what the rapid response team does and what their recognition was by the OB triage where this patient was. And it really reminded me of a story as I was debriefing a group of ICU nurses. Suddenly the room got quiet, and one of the nurses tearfully spoke up to me and said that they had a physician that they knew this order was going to kill this patient. They knew it. And none of them could speak up because they were so intimidated and so afraid of many things, losing their job, being ridiculed. And it actually happened where this occurred, and the patient died. And I wondered, was every single nurse who interacted with this patient not aware of what was going on, and what systems could be in place to prevent that from occurring? And definitely running through, how do you make the decision, and what are the clear markers for decisions between being in triage and being admitted to the unit? What criteria do you need to meet? Just simply having criteria, which I am sure this patient would have met criteria for admission. So do they have that criteria? Is that in place? These are the types of systems supports that keep you out of trouble with patients.
So like a scope of services is what, like.
Absolutely.
And we got a podcast coming up on that as well, if you're wondering what scope of services is about. So, yeah, I mean, they delayed in triage. She was there almost a whole day before they called RRT. And they called the RRT to get an IV, which we'll talk about kind of the culture issues there. But, an RRT team is not an IV team. And yes, they're probably very skilled at IVs, but that's a systems issue when your RRT team is not being used to their full capacity. And then once they recognize there's all kinds of delays and obstacles in getting the patient to the ICU, that reported in somebody getting in trouble for doing what they thought was the right thing to get this patient up to the ICU. And clearly it was, because she was in shock and got intubated and was there for days upon arrival. And, so instead of supporting that person who stood up and did the right thing, that person got punished, which doesn't bode well for the next patient who needs somebody to stand up for them.
I know. Will that nurse do it the next time? Will they do the right thing? I mean, I understand if there's no ICU bed, but then you bring people to the bedside in OB to stabilize this patient until you do have a bed to put the patient in the ICU, if that truly was the case, And in fairness, we don't have the chart. We don't have, we don't have interviews with that team. So, there could have been no beds or no nurses except for the one that was bringing her up. But there clearly needed to be a process, a system and process in place to care for a critically ill patient, even with no beds open in the ICU.
Absolutely. I mean, critically ill patients can be anywhere. And yes, we may want them in an ICU setting, but that doesn't mean that they don't get the critical care that they need until they are in the physical location where you want them to be.
Right. They don't just wait there until some bed opens. I mean, you have to still care for them within the standard of care. And where that is just environment.
Exactly.
So, Julie, like, if you were to talk about doing simulation for sepsis, like, is this hard to do from your perspective? Is this easy to do? I think it may be a little overwhelming. I'm going to guess that this facility is probably not doing a lot of simulation. That's a complete guess. I have no idea. But when we see these kinds of issues, it often means that teams are not practicing together. So what does that look like?
Well, I think for sepsis, it appears on the onset to be a fairly easy simulation. I mean, it can be fairly short because basically, if you understand what your bundle is, what your 1 hour bundle is, and what the criteria are to take the next step, that's pretty easy to sim. And quite honestly, the biggest complications we've had out of implementing that for that 1 hour bundle is, why doesn't the OB unit have culture tubes on the unit? I mean, like minor stuff like that. But what's more difficult about sepsis is exactly what this patient experienced. When do you need to escalate to the next level? And how do you make the other units understand that an OB patient can be just as sick as any other patient in the hospital? So that's where the simulation in conjunction with the emergency room, so that it's recognized, whoever is seeing this patient first, so that they recognize the hallmarks of sepsis. And then how do you get the appropriate consult and the appropriate level of care as fast as possible? How do you smooth that transition out so that that patient moves from the unit where she was, which was OB triage for 8 hours, into the ICU without someone just taking the patient up there and dumping the patient on the unit? Those
Yeah,
are hard
exactly.
questions.
Yeah, and I want to remind the listeners that this patient, before she came into the hospital to OB triage and sat there for the whole day, she'd actually been coughing up blood. Okay, so like that's not normal postpartum. But they put her in OB triage and then continue to normalize the abnormal. And it's just anxiety. It's just anxiety, or it appears that way. So we've talked about normalizing the abnormal, some examples of that. There are many. Lots of systems issues. There are probably many more than what we identified. We just highlighted kind of what the obvious ones. And then knowledge deficits, which honestly, knowledge deficits are probably the easiest ones to fix and that's usually where, in our experience, most people go. They say, oh, we had a bad outcome. Everybody needs to read this chapter or do this webinar, and that's going to fix the problem. Sign here. I need email proof that you've completed the task and check we've solved the problem because we've taught you about sepsis. It's so much more than that. So, but I don't want to diminish the importance of knowledge, but having practice and having standards in place can limit the impact that lack of knowledge has.
Yeah, and
So,
remember that is when you look at the Maternal Mortality Review Committee data that's out there, all of the data from many, many states across the country in the United States, um, knowledge deficit and knowledge and then management. Those are the top two reasons that patients die, as far as categorization, when you look into the patient case study. And that is a huge opportunity to improve our knowledge and improve the knowledge of the patient. And I remember this patient said that she didn't have any kind of early warning criteria to address when she went home, even though it was questionable whether she should go home or not. It was never taught to her, that she didn't even know. And in fact, she just thought it was all based upon her anxiety. But that under that knowledge of it comes so many categories about, we highlighted one of them, just understanding how quickly pregnant or postpartum patients can deteriorate. And they will be talking to you. And we've heard case after case where they're talking to you. They look normal. They, they may not even have the abnormal symptoms that this patient was clearly screaming, and then they are intubated or comatose state in the next 30 minutes. So it is these patients trek up that hill, trek up that hill, trek up that hill, and then they dive off. So it's really important.
I think this is where looking at your own cases very honestly in simulation is important. And I know many people in simulation will not use one of their own cases, particularly if there's a bad outcome. And I think that's a huge lost opportunity because you have the ability when you're looking at your own case to really delve in and look to see where did it break down, where did our process break down, what deficits and what gaps do we need to fill? Why didn't this patient with these signs and symptoms move through this system? And it's not, it should not be done in a way that blames anyone. It's more of a curiosity. It's a discovery. It's looking at all of the wisdom that the staff have in that debrief of that particular situation and that hospital. How do we fix this so that it doesn't happen to another patient? And for most of you who are working on a regular unit, you know exactly what the fix probably is. So being able to say that and bringing it out in simulation and then following through. I remember in one debrief that we did, kind of alluding back to the debrief where they knew the patient, this particular order was going to kill this patient and no one spoke up. What we did in debriefing, once everybody calmed down a little bit, is to say, what would it take to help you stand up? What do you need to have the ability to advocate for the patient at this point? And they listed several things on their unit, very specific to their unit. And that was communicated to the nurses in a huddle. So there are things that you can get out of these terrible events by just going through the simulation process with that particular case.
Yeah, and I think, to your point about use your own patients, your own situations to simulate, people get real, I don't know why there's such a, maybe it's the lack of control. There's too many variables. They're not sure how they can implement it because there's so many things going on. But, the thing we consistently hear when we talk about these cases, when we present these cases, when we discuss about issues, people go, that would never happen. That can't happen. That would never happen here. And when you're using your own case, well, I'm sorry, that argument is not valid. It happened here. I mean, I don't know why people are so willing to say that would never happen when it clearly is happening.
Yeah.
So, yeah, I think it's a great point. I mean, other knowledge deficits here, there was clearly no recognition of critical illness and no recognition of sepsis or septic shock. She was in triage all day long. I mean, even once she went home and came back, nobody recognized. They just were labeling her. It appeared that she had gotten the label as an anxietal problematic patient, and people were taking her less seriously. I mean, this woman had 9 of the urgent maternal warning signs that she was communicating consistently, and they were just flat out ignored. It was blamed on anxiety. Normalizing a low blood pressure, because they're saying that's what she runs, and that's what she was in when she was in the hospital before. Well, I don't know what the blood pressures were, but clearly they weren't normal. This woman was, in an intensive care unit in septic shock. And being told that sepsis is so rare as an excuse, really, or as an explanation for the things that were going on. Well, sepsis is not that rare, and it's going to be extremely rare if you don't know what you're looking at and you never label the patient as septic, but it's just not that rare. And you've got to be prepared to recognize it and deal with it.
I think one of the things you said, I think bears repeating, because I have heard you and Suzanne talk several times about use of mean arterial pressure versus simply systolic or diastolic pressure to really begin to determine, is this patient critically ill, or is this really a normal finding for this patient? So can you review that for the audience real quick? Because I love the way that you talk about that.
Yes. So, in pregnancy, people talk all the time, your blood pressure lowers, your blood pressure lowers. And that is true about your systolic blood pressure. It does decrease when you're pregnant. But your mean arterial pressure does not change because you're pregnant. It stays roughly in the mid 80s for most patients. And in shock, in septic shock, is a mean arterial pressure of less than 65 millimeters of mercury, despite fluids, et cetera. So a mean arterial pressure of less than 65 is abnormal until proven otherwise. It's not, you cannot say that a mean arterial pressure of less than 65 is normal by default. There's probably some patients where they live at a mean arterial pressure less than 65. They're also not going to be symptomatic. They're going to have a normal pulse. They're going to have normal other vital signs, and et cetera. But in this setting, a mean arterial pressure of less than 65 is abnormal. The mean arterial pressure calculation is driven primarily by your diastolic pressure, not your systolic pressure. And that's why it doesn't really change significantly during pregnancy. So you don't have to look at the number to know, like the systolic, diastolic, that mean is so helpful because it really doesn't change. Pregnancy doesn't influence normal in that.
Well, and that mean arterial pressure is at your fingertips every single day. That is the number in parentheses next to your systolic and diastolic blood pressure. So you have, of course, trash in, trash out. If you don't have a good blood pressure, if you're not taking an accurate blood pressure, then you may not have as accurate an MAP or mean arterial pressure, but an accurate blood pressure is always going to give you the mean arterial pressure in parentheses that you can utilize with confidence in determining, is your patient being perfused or not? And that's what we're talking about here with a mean arterial pressure, at least of 65. It has to be that to perfuse. And you have to perfuse if you're going to live. So, I mean, it's pretty straightforward that way, using the mean arterial pressure.
Perfusion is life.
Yes.
So we've talked about normalizing the abnormal, systems issues, knowledge deficits, and let's close out with culture. We've been kind of hinting at culture and talking about culture up to now, but what really resonated with us as we were listening to her story is there's a complete lack of a culture of safety. That came through real quickly. Otherwise, none of the things that we've been talking about would have been possible in a culture of safety.
I agree. And that culture of safety is very difficult to address. I think one of the main ways that you can do it, again, is through simulation. And if you can develop ways that you can support each other as a team, develop ways of communicating where there are issues as a team. For instance, the debrief that I keep talking about, where the nurses didn't feel like they could step up, they developed a very simple strategy by simply calling in another nurse, and they had an indicator, and that nurse just simply stood next to the other nurse, and they together confronted decisions that they thought were harmful. Now, obviously, there's going to be some disagreement at times. There are going to be times when what is being ordered is exactly the right thing. So how do you sit down and communicate that? You can't do that when you're actually in the patient situation. This is something you do in simulation. And that's why in a situation like this, with this type of a sepsis simulation, it's, for me, less about education, because how simple can it be to do 4 things in an hour that we do every day? Order, give IV fluids, get a lab, and start medication. We do that all the time. So what's really important about simulation and simulation for sepsis is these communication. This is my priority. What's your priority? This is an obstacle for me getting this done. How can we work around this obstacle? This is what is concerning to me. And talking about this as a team, this is where truly the simulation needs to be mostly about the debrief. So the team can learn about each other and learn how to manage these very complex patients in a way that supports patient care and also supports the team. For instance, one of the sepsis simulations that we were running, there was a question about timing of delivery. And the question was, can we do a C-section on this patient? And the chief anesthesiologist spoke up and said, that's not the right question. The question is, can this patient tolerate a cesarean delivery? That's a very different question than can you do one? And that made everyone in the room think about, okay, there are complications that we see in C-sections. Is this patient going to be able to tolerate this complication? So I think that type of rich discussion really moves everybody forward in their understanding of sepsis and what these actions, what impact these actions are going to have on the patient to get the best possible care.
And having those conversations together starts moving the team closer to a culture of safety. But, ultimately safety comes from the culture comes from the top down. So while bedside providers have a major role in what culture looks like, those kind of things need to be supported by leadership as well, and encouraged. Otherwise, this is why people leave. This is why they burn out. This is why they leave. They migrate to other institutions, because if leadership doesn't support that, most people aren't going to thrive in that type of environment. And when you don't have a culture of safety, we commonly see cultures of blame and shame, because everybody's finger pointing and looking at it as an individual problem instead of a systems approach, a culture approach. I'll never forget, there was an episode of ER, so I'm going to date myself. Many of you listening are like, I have no idea what she's talking about. But there was a show that was very, very popular back in the 90s called ER. And George Clooney was one of the stars, and that was not why I watched it. But I remember very clearly, Juliana Margulies played one of the ED nurses, okay? And she was like that smart, tough, capable nurse that was frankly smarter than all the residents, and really a leader in the ED. That's how I remember. Haven't watched it in years. But there was one episode that I have never forgotten. And it was an episode where a trauma patient came in and that needed blood transfusion. And Juliana Margulies' character gave the transfusion, hung the blood, but it was the wrong unit of blood, and a bad outcome occurred. And it became all about whose fault was it. And that was the first time I started thinking about things as, listen, she hung the wrong unit of blood, but was it really her fault? Like, what led up to that event of her hanging the wrong blood? Yes, we can fire her and shame her and blame her, but somehow this event occurred. And if we just blame her as an individual, we're probably not going to prevent the next error. Right? And I've just never forgotten that. It really stuck with me in we need to be looking at these things differently. Certainly there are bad actors. Certainly there are people who will not improve, who do not try to improve, or are known problems. Yes, but that's not the majority of the time. The majority of the time, everybody's there really trying to do their best, wants to do their best, wants to improve, is receptive to feedback and education and learning. And we have to have a system around everybody that supports that and that supports doing the right thing.
I agree. And I think two of the most powerful debriefing questions I ask when we have identified an ideal practice is, how can we make sure this happens on the unit every single time? And when we identify a practice that should not happen, How can we prevent this from ever happening again on the unit? And it brings it right back to, what are you doing every day in your work that can either result in the right thing happening for the patient, or could potentially lead to the wrong thing happening to the patient. And that's simply culture, being able to speak up and process, having a process in place.
And then lastly, the thing that was really evident to me by a couple of comments that she made in her story was a real distrust amongst the teams. If it wasn't there before, it's certainly there after. And to me, it was most striking between the ICU and the OB teams. Now, if you're in the ICU and you get this patient and you've seen what didn't happen leading up to her ICU admission, how much confidence do you think that ICU team has in the OBs? Now, I mean, they're all thinking, I'm not having my baby here, right? I mean, they are terrified because to them, they know what should have been done and wasn't, and therefore they don't have trust. So she described how, the OB, once she was in the ICU, I guess the OB team was trying to offer support or insight or whatever, and the ICU team was really not receptive to it because they did not have confidence that this team knew what they were doing. And quite frankly, it doesn't sound like they did know. At least the team leading up to, maybe the ones coming in after knew more, but the patient had really been let down by what happened. And so I can completely see that lack of trust. And it takes a lot to build that back once it's gone.
It really does. And it speaks to me of an inability to clearly communicate what is going on with the patient in the terms that that particular department understands. So I have heard, and I'm sure you have too, times where the RRT is called and it's like, oh my God, this is not an RRT. So really clearly understanding that criteria and knowing what that process is in your particular hospital is really important. And it reminds me of a hospital that I was working with, and the OB unit was really having a hard time getting the massive transfusion to their unit. And they would pick up the phone, they would call the blood bank, they would explain how this woman's going to die, they would explain how this patient really needs blood. And it didn't work until they figured out, you pick up the phone and you say MTP, massive transfusion protocol, and the blood bank really didn't care about anything else you had to say. Now they knew what to do and they were going to go do it. It's a simple process, understanding the process. And I think between units, those types of communication and understanding how those communication can drive care is really, really important. That's why it's so critical to do simulations with these units that you interact with on a regular basis, so you have an understanding of what the strengths are that each individual brings to that plan for the care of the patient.
Absolutely. And, the other thing that struck me before we kind of start wrapping it up here was your rapid response team is more than just expert IV starters. Your rapid response team has a wealth of knowledge and experience. Now, they may be out of their depth when it comes to OB. We hear that a lot. I don't call it the RRT because they don't add anything because they don't know anything about OB. Well, there's a knowledge deficit there, and there's an opportunity to practice as well. And by the way, with our academy, the Critical Care Obstetrics Academy is a great place to start if you want to get a foundation of knowledge in obstetric high risk and critical care. It's intended for nurses and physicians. And so any RRT members or those of you who are thinking they don't know what they're doing at my hospital when I call an RRT, that's a great tool for them. But they're more than just IV starters. They have an opportunity. I mean, they are a huge resource for you in your facility, huge resource. And if you don't know what they do and don't trust them, that's a major lost opportunity, lost opportunity. And that you're going to have to practice and get comfortable with that.
Yes, they have the fast track to getting to that ICU, as this case demonstrated in one way or another.
So from our perspective, we really want to help teams. We hear these stories all the time. And so we hope that hearing about cases like this, really fuels everybody listening to figure out what you can do at your own facility. How can you get better prepared to recognize and deal with these issues when they come up? Really to look at your own system with complete honesty. You may think this is not happening at your hospital, but something similar to it likely is. It's still happening all over the country. One of the things that we do in our company, Clinical Concepts in Obstetrics, is we go to facilities, we observe what's happening. We talk to people, we tour, we read policies and procedures, and we help teams figure out in an objective manner what their issues are and where we think they need to dedicate their resources to improving care for high risk and critically ill pregnant women. Plus, we can educate your team. So how do you remove these obstacles? How do you know what these obstacles are? We're kind of like that objective third party coming in and giving a voice to the teams that already know what the issues are, but don't know how to get people to listen. So, you can find us at our website, clinicalconceptsinob.com, and that's where you'll also find out information about the Critical Care Obstetrics Academy. And sign up to review our webinar, The Top 3 Mistakes in OB Critical Care. We appreciate all of our listeners. Don't forget to subscribe, leave us a review. You can learn more about us at clinicalconceptsinob.com. Follow us on all our socials, Facebook, Clinical Concepts in Obstetrics, Instagram at Critical Care OB, X at OB Critical Care. And as always, reach out and email or DM us for suggestions on future podcasts.
This podcast was produced by Austin Baird. Are you looking to create a podcast? Please email me at podcastnashville@gmail.com. That is podcastnashville@gmail.com.